Thanks for coming to this episode of the Dean's Lecture, where we celebrate the accomplishments of our faculty who have been promoted to the rank of professor. And today I'm very happy that we're able to do that with Lisa Jacobson. And Lisa, you know, we've just both been told that there's an event here at 5, and Scott is over there looking serious and saying we have to finish by 5, so I won't take a long time in the introduction, except to say that Lisa is somebody who, despite her accent, is really a Hopkins woman, right? Came here from New York to go undergraduate school, got her master's here, her doctorate here, and except for a brief stint away, has really been here ever since. And during that time, she's worked in the Department of Epidemiology on HIV, doing really a seminal study that we're going to hear about, I know. She has been a mentor, I know, from colleagues that we've shared together for faculty who have been doing epidemiologic research and the interface between the doing and the thinking about, and she's been a leader in that. And you know, I always say that it's an incredible accomplishment to be promoted to faculty, to be promoted to professor in the faculty at Johns Hopkins. And it's not something that we give. It's something that people from around the world do for you. You know, our colleagues write letters, and I remember reading I read the letters as they come in, reading Lisa's letters. And the overwhelming theme was from people who have seen her function in professional settings was her incredible ability to collaborate, to bring people from very different backgrounds and convince them. You know, one of the problems with being an epidemiologist is that you're sort of seen as a Cassandra. You know, you're always worried about methods and data validity, integrity, and it takes real skill to get people who, by their nature, don't care about those things, to care about them and to do a great job. And you've done that. You've earned the respect of everybody who's worked with you. So she's going to talk about, I think, some of the exciting work that she's doing, but her passion is really, as mine used to be, observational studies, cohort studies, and the ability to do. We talk about team science and the importance of that for science in the 21st century, and Lisa does that. So Lisa, we look forward to your talk.
And what I will be presenting today is the result of a lot of teamwork, as you'll see. It's going to be very hard for me not to move around, but I was told I had to stand. So here, if you can see me, I'll maybe wear heels. Yeah, okay. I can't see you. So today I'm going to talk about distinguishing the effects of HIV therapy and age and some of the lessons that we've learned from the cohort studies in which I'm involved. Why is this important? Well, as you can see here, a large group, almost 1/3 of individuals living with HIV today in the United States are age 50 and older. And this has been estimated to be growing such that even in a few years, more than half the people living with HIV in the US will be above the age of 50. So I'm going to be talking to you a lot about HIV and aging research that we're doing in the Multicenter AIDS cohort study in particular. So here's the Multicenter AIDS cohort study and the Women's Interagency HIV study in a nutshell. They're both prospective cohort studies. They both have semi-annual, that is every 6 months, these individuals who were enrolled come back to their sites. They're multi-center. In the MAX, the sites are located here in Baltimore, the Baltimore, Washington area, in Pittsburgh, in Los Angeles, and in Chicago. And in the WIHS, they're located in the Washington area, Los Angeles, San Francisco, Chicago, and there's 2 in New York. The data center, for which I'm very happy to be involved, is right here at Johns Hopkins. The MAX got started in 1984, and the women's study about 10 years later. We are currently in visit 57 in the MAX, an incredible endeavor that some of these men, particularly the HIV negatives, have been coming back every 6 months for over 27 years now. Absolutely incredible. The outcome ascertainment, it used to be that was strictly AIDS, and now it's cardiovascular disease, liver disease, kidney disease, et cetera, are confirmed by medical record review. I say here 6,972, but there's actually more individuals that are being enrolled in both cohorts. It is more of a dynamic enrollment going on where some individuals are actually being actively recruited today. There is a presence, and a very important presence, of older people in these cohorts. For example, in the MAX, we're currently following approximately, or are supposed to use this and not the pointer, sorry. We're approximately following about 1,400 people who are over the age of 50, and in the WIHS over 1,000 women who are over the age of 50, in the cohort. And so these are the individuals who can contribute a lot to understanding effects of HIV and aging. And among those individuals, as you can see here, we're following individuals currently, and most of whom in the positives have initiated HAART at some time. In addition to these cohorts, I also want to mention the NA Accord, which is a consortium of all HIV cohorts in the North American continent, area, I should say. And the PI of the data center is Stephen Ganji of the NA Accord. And currently, they have data on over 20,000 HIV-infected people ages 50 to 59, and 7,000 who are actually over the age of 60. So between all of these cohorts, and I didn't even mention the ALIVE cohort also ongoing here, we have very good observational data to examine some of the effects that I will be talking about. The cohort is heterogeneous in terms of race. Very interesting, though, you can see that even today, in this era of effective treatment, a third of our cohort seropositives who are between ages 50 to 59 years are on disability, and about a quarter of those younger than 50 are on disability. So what do we know about age? Even in the natural history, what do we know about age and HIV? Well, we do know that there's a dramatic effect of age on HIV incidence, that the younger you are, the more likely you are to become infected, and the older you are, the less likely. However, due to work that, like my colleague Carrie has been showing, it's not that individuals who are older are not becoming infected. She has estimated that close to 3% of MSM who are over the age of 50 are newly infected with HIV. What else do we know about HIV and AIDS prior to the history of treatment? Well, we also know that the older you are at the time of infection, the faster progression to AIDS. So an individual who is 40, for example, have a much greater chance of developing AIDS quicker than individuals who are in their 20s. Okay, and work that a doctoral student has just published, David Hanna, using data from the HIV surveillance data of 37 states and the national vital statistics data, has shown that today, the older you are, the more likely with those with HIV that you are going to die. And so these are national data. Now you may think, well, of course, the older you are, the more likely you're going to die. That's true every day. But it wasn't always true in HIV, okay? Remember that in the earlier years, if you developed AIDS after having been infected with HIV for a median of about 9 years, you had a very, very short survival, where the median times of survival was 1.5 years or less. And that if you were older, it didn't really make any difference if you were older than 50 when you developed AIDS, because for everybody, it was a devastating disease with a very poor prognosis. Now, in the era of HAART, highly effective antiretroviral therapy, where people can survive their HIV and their AIDS, we see this effect that if you are older than 50, you're almost twice as at risk for dying more quickly after your AIDS diagnosis. Okay. So there are similarities that has been shown from the research in HIV and from the research in aging that are between HIV and aging. So at the biological level, we know that there's a decreased cellular immunity that occurs both with HIV and with aging. Matter of fact, the T lymphocytes are senescent. They have shortened telomeres with aging and produce less telomerase. They're less likely to proliferate. And there's an increase in the pro-inflammatory markers that happens both as people get older, such as IL-6, TNF-alpha, interferon gamma, increasing, and these have also been shown to increase with HIV. At the clinical level, we also see conditions that occur with aging and with HIV that are very similar. This weight loss, this loss of muscle, cognitive disorder, declining dementia. We know about HIV dementia, Alzheimer's, and other dementia that are associated with aging, rheumatologic disorders, bone mineral density decreasing, and this frailty-like clinical presentation. So now let me go a little bit into frailty. And I want to thank Joe Marglick for this slide, although he thanks Dr. Ferrucci for this slide, and then he generously provided it to me. So basically, when individuals are seen in their aging, there's a neurodegeneration that occurs, a dysregulation, the homeostasis of the body is occurring. They can't produce the same amount of energy. We see changes in the body composition as well. And these all go into this phenotype called frailty, where you're more susceptible to other diseases, where you're unable to respond to stressors, and therefore your health becomes very unstable. And what we see then is individuals who fall, who are more prone to fractures, who have sleep disorders, who have urinary incontinence, et cetera. So Linda Fried defines frailty in geriatric medicine as a clinical state of vulnerability to stressors. And it's a poor outcome. It's associated with falls, hospitalization, and death. So using her definition of frailty, an individual is defined as being frail if they present with 3 of these 5 components. That is, they show physical shrinking. And this may be unintentional weight loss. They're becoming weaker. Their grip strength is becoming more and more weak. They're exhausted. They can't walk as much without becoming tired. It takes them longer to walk, measured walking, and they have very low physical activity. So why is this important? Well, as I just mentioned, it's been associated with adverse outcomes in the normal population, in HIV-uninfected populations, and probably in HIV-infected populations as well. It's associated with untreated HIV, but it may even persist now in the HAART era. It may be treatable or preventable. There are studies out there that show with exercise, change of diet, et cetera, that those who were frail become less frail. And also the better understanding of mechanisms of frailty would inform treatment and studies of non-HIV frailty as well. So in the MACs, we first defined a frailty-like syndrome or frailty-related phenotype because we didn't have all the components. So for example, we had the unintentional weight loss. We did not have a measure of grip strength. We had a self-reported measure of exhaustion and slowness and low physical activity. So we basically said if you have 3 of the 4, we defined you as having a frailty-related phenotype. And looking at this frailty-related phenotype and controlling for age and education, ethnicity, the CD4 cell count, which is a marker of disease stage in HIV, and the amount of HIV RNA that is circulating in the plasma, we examined all visits between visits 21 and 41 at that time among the HIV positive and HIV uninfected individuals in the MACs, and basically showed that with duration of HIV infection, the prevalence of this frailty-related phenotype increased. We also showed that the prevalence of FRP for a 55-year-old man who was infected only for 4 years was very similar to what has been published and what we showed also in our cohort to that of individuals who are uninfected and are over the age of 65. Okay. And this work, I have to say, was led by Loic Desquibet, who was one of my postdoctoral students. This is looking at the prevalence of FRP according to CD4 cell count And as you can see, both for a 55-year-old and both for a 40-year-old, you can see the difference about the older, but you can see the same general relationship that the lower the CD4 was, the higher the prevalence of FRP. You can also see at where you get to very low CD4 cell counts that these lines begin to converge. And it really didn't make a difference what time period we saw that this relationship between CD4 cell count concurrently, whether you're under treatment or prior to treatment, early prior to treatment, remained the same. Although that among those who are in the treated area, which would be these two lines, it is a lower prevalence than those in the earlier era. So what about FRP? We're in the treatment era now. It doesn't make any difference. Well, if you had the frailty-related phenotype prior to even starting HAART, you saw this increased risk of developing AIDS under HAART, of developing AIDS or dying. And if you looked at the quantity, the burden of FRP in these different visits prior to starting the HAART, with the more increased burden or persistence of frailty, it tripled your risk of an earlier AIDS or death after initiating HAART. And this is controlling for age at the time of HAART initiation, which also you can see strongly affects subsequent development of AIDS or death. So what we've seen and shown is that HIV infection was associated with about a 10-year early occurrence of this frailty-related phenotype. It increased non-linearly with decrease in CD4 cell count, that even after adjusting for age and CD4, it decreases after the introduction of HAART, but we still see the relationship with the decrease in CD4. That older age, lower educational, and clinical age were all independently associated with FRP, and that it independently predict a poor prognosis after starting treatment, including among those who were suppressed with HIV RNA after starting treatment. This is current work that is undergoing, that has not quite seen the publication, but because we're now even adding more visits to it. But this is basically showing by age in the negatives and positives. And now this is no longer the frailty-related phenotype. This is now the frailty phenotype, because we've now included hand grips and timed walking into the MAC. So every 6 months, these individuals have to grip this instrument with both hands, and they have to walk this 4-meter length of walk. And we've gone around to each site to measure that meter walk to make sure it is 4 meters. And you can see that in the younger individuals, there's no difference between the negatives and positives. And in the oldest individuals, there's really no difference, a slight increase, but no real difference between the negatives and positives. But it's in this middle ground, this 50 to 70-year-olds, that you see this earlier occurrence of a slight increase starting in the prevalence of the frailty phenotype that you don't see in the seronegatives. Comparing to the HIV positives, and this is among those who are suppressed, meaning they have no detectable HIV RNA, and this is looking at everybody. Comparing to the seronegatives by age, you see this increased prevalence ratio among all the seropositives in that age compared to the negatives, and even among those with suppressed HIV RNA compared to the negatives. In terms of looking at the predictors right now, we see, of course, this very strong age effect. And we see that the strongest effect are those with a previous clinical syndrome or clinical illness that is definitive of AIDS. We see an effect with hepatitis C and smoking, and also with depression. So very importantly, frailty phenotype is measurable in the HIV positives. Right now, the total clinical impact of the frailty phenotype is unknown. But we do feel that there's a lot of additional longitudinal studies that are needed, as well as studies looking into the mechanism as why some peoples become frail, why some peoples become less frail after becoming frail. It's really important, though, to have the proper comparison groups. And you have to be careful when you start comparing HIV positives to the general population. And why? Because of what we learn in Epi, confounding and bias. Okay? The two biggest reasons. One is typically HIV-infected populations have a totally different age structure, as I will show you. Also, HIV-infected people have different risk factor profiles than HIV-uninfected, besides the HIV infection themselves. One is they had these behaviors that led to becoming infected, and those same behaviors themselves could result in other morbidities, et cetera. Also, they have higher rates of co-infections, such as Kaposi sarcoma, herpes virus, such as hepatitis, and other behaviors, such as smoking. In terms of bias, HIV-infected individuals are followed differently. So they are more prone to diagnostic bias, of finding things out earlier than they would in uninfected individuals because they are seeing clinicians because of their HIV and because of being on medication for HIV. So this was a paper that was published by Meredith Shields. This doesn't use our cohorts, but she was a student here, so I thought it would be important to show it. And this is basically showing the age distribution, and you can see the very different age structure in those with AIDS versus the general population. So if you were looking at the ages of those with a clinical event, such as those with cardiovascular disease in HIV-infected, and those with cardiovascular disease in the uninfected, you'll say, it occurs earlier in the infected. And why? Because those are the individuals who you are following, the younger individuals. And so in her paper, what she showed that once you correct for the different age structure, you no longer have some of the differences that were being published. For example, not only do you not have a higher incidence, but in colon cancer and prostate cancer and breast cancer, what you observed in the HIV positives, which are the solid line, is actually lower than if you correct for the age structure in the general population. You do, however, see for some illnesses increased rates in the HIV positives, and this you see in lung cancer, anal cancer, Hodgkin's disease. So this is a paper that was done in the WIHS, and basically this is looking at 14 incident lung cancers during the 25,000 person years. And you can see that this increase here, that it shows that in HIV positives, there's a doubling of the risk of lung cancer, although the confidence limits, it's very wide and it's non-significant. However, if you look at it compared to the US population, it looks like it's triple the risk with a significant confidence interval. One thing that is very different is the smoking. And we know smoking is related to lung cancer. So for example, in the WIHS, almost 68% of the WIHS women smoke, compared to the US population where only 37% of women smoke. So given that, and given that smoking is such an important risk factor for lung cancer, we recommend then that the comparison be made to internal control group, to the seronegative in the WIHS, and that the doubling of the risk provides a better estimate. And there's work ongoing now to improve the power by combining both the MAX and the WIHS to look at lung cancer risk. And so Eric Seberg looked at various cancer sites as well, and did both the standardized incidence rate compared to the US population, and the incident rate ratio compared to the HIV negatives in the MAX, and basically has shown for many of them, the standardized incident rate is actually underestimating, and this is age, race, and calendar period adjusted. For example, why? Again, even in the MAX, we have a high rate of smoking, but look at the use. We have a high rate of use of other non-prescribed medications. So whereas like almost more than a third of the younger men are reporting frequent use of marijuana, frequent use of poppers, and also we have a relatively high rate of use of crack cocaine and other uppers and other speed. So what's important is that our negatives, we collect the data the same exact way, and they report very similar overlapping results. So allowing us to then account for the confounding based on these potential risk factors. Okay, what are some of the current age issues? And I have to keep my eye on the time. Well, how does age affect the effectiveness of treatment? Now we start thinking as people are surviving, we think of HIV as a chronic illnesses, but there's the question of, is aging with HIV, is the immunosuppression of HIV, or the therapy itself leading to higher rates of these comorbidities or these morbidities that occur at an earlier age? Basically, age is now the time scale of interest. It's no longer time from seroconversion because people are put on therapy. So now age is the important time scale. And in particular, when we think of earlier aging, et cetera, what's the ultimate endpoint? Death. Okay? Are the individuals now surviving so that their life expectancy is the same as uninfected individuals? And so I'll be showing you some work that we've been doing in that area as well. First of all, in looking at infectiveness, if you look at individuals who are younger than 35, and they start treatment, let's say less than 350 CD4 cell counts, between 5 and 10 years later, the median CD4 cell count is about 550. If you take individuals who start therapy and they're older than 50, and they also start at less than 350, you can see that they do not have that same rebound in CD4 cell count. As I mentioned, there's a whole process going on with the immune system as one ages that is in addition to what you would see with HIV. So in order to see equivalent CD4 recovery, these individuals have to start at higher CD4 cell counts than the 350. Okay. My colleague has shown that compared to HIV negatives in the MAX, that HIV positives under treatment have a 4-fold increased risk of diabetes. This is very exciting. This is work that we have done now on actually measuring the kidney function in the cohort. One great thing about being at Hopkins is this cross-collaboration between and learning from each other. So my colleagues have the data center for a cohort in children looking at chronic kidney disease, and we learned from them how to measure kidney disease or kidney function and incorporated that into the MAX. And therefore, this is actually injecting with iohexol and infusing with iohexol and looking over time. And this is the GFR distributions. You can think of these large solid bars as the 50th percentile, the median. And then this would be the 25th percentile, 75th percentile, et cetera. What has typically been thought of traditionally as indicators for decreasing kidney function is like stage 1 is below a 90. So that's what this line here is. This horizontal line is at a GFR of 90, and this line is of a GFR of 60. And you can see these blue ones are HIV positives, and you can see starting at relatively younger ages, the tailing of the distribution going down further in the HIV positives, or more of the HIV positives. It's not a lot. Let me tell you, it's not a lot. The majority of individuals are in this normal range of GFR function, but the interest in GFR function is this tail. And we see this decreasing in the tail going on more in the positives, especially in what we can typically consider the middle ages. Okay. Another study that was done looking at anal cancer, again, comparing to the HIV negatives being followed the same way, getting the medical records the same way, reviewing them blindly in terms of what their serostatus is. My colleague Amber D'Souza has shown that the HIV positives in the current HAART era are more likely to develop anal cancer than the HIV negatives or than that which we saw in the pre-HAART era. This is looking at neurologic disease. And this is study visits, so it doesn't mean much. But what it's saying, and this is the distributions and the longitudinal data for the HIV uninfected, and this is the longitudinal data for the HIV positives. And the longer you take to do these trail making, the worse it is, okay? So you want to have a short time to do this neurologic test. And you can see for the negatives, and this is the younger ones, the next age group, and the older age group. And you can see, yes, it takes older people, sadly I'm finding this, longer to do things. Okay? So it takes them longer to do things, but it always takes them longer to do things, and there's basically no change over time. That's always taking them longer, but basically it's relatively flat. However, in the HIV positives, you can see this increasing, that's actually taking longer as these older individuals are further aging and with time, that it's actually an increased slope, and that's a significant increased slope that was shown. And the incidence of neurologic diseases, you can see, are dramatically has increased in HIV positives pretty much at every age, but you see this, when you look at stroke, you see this dramatic increase compared to HIV uninfected in our cohort. So this is a quote that it's a field still in its infancy. There's still a lot for us to learn. So we need to look at this issue of premature aging. What does that mean? And we need to understand better, what is the normal biological process of aging? What do we expect as individuals get older mechanistically in order to know whether or not that is different in HIV positive individuals? So one thing people are looking at is markers of inflammation. So this is another paper that we did in AIDS, and these are just some of the markers: soluble CD30, soluble CD27, IL-6, and C-reactive protein. And basically, these two time points are prior to treatment, and these two time points are after treatment, and these are an HIV-negative group. And you can see for some markers, yes, treatment has a dramatic effect. Does it go down to negative? No, not in this preliminary data following initiation of HAART. I have to say that we recently been able to test 13,000 person visits over the natural and treated history of HIV, in addition to having longitudinal visits for seronegative individuals to look to see how these markers change with HIV and with prolonged treatment. But not all markers change with treatment. And when we think about confounding, well, even then, we get to capitalize on having these seronegatives and looking to see what factors in the seronegatives affect these markers, and therefore we need to think about whether or not they would be confounders when we think about the seropositives. And for example, among those with chronic hepatitis C, we see a dramatic decrease in high sensitivity CRP. And we know that HIV positive or infected individuals are also co-infected, a good proportion of them, with hepatitis C. So we do know we will need to account for that or adjust for it in our analyses. Lastly, I talked about, well, what's the ultimate outcome? And that is death. So this is work that was led by now a postdoc, Dr. Wada, in our group, and this is basically looking at life expectancy among individuals who are age 35. So yes, we're not doing it from the time you were born, we're doing it among adults with HIV, and we're comparing them in terms to seronegatives, and he used a competing risk or proportional hazards in order to look at cause-specific, whether or not it was done if they died from AIDS or non-AIDS. And I know it's a complicated graph, but it's a really important one. It's very exciting. So the solid line, black line, is the life expectancy, or basically the time individuals will expect to die among the HIV uninfected individuals. And the median time is about 75 years of age. Looking in the and that's in the max. In the Ys, looking at the uninfected women in the Ys, it looks to be, the median time is about 11 years younger. That their median time of death is about 64. And then in the max, if you look at the individuals who are dying, but they're dying from a non-AIDS illness, so they are not dying from AIDS. The question is, do they have the same life expectancy? Well, sadly, they do not. And so it's this difference between like the 66 and the 70, this 8-year difference here, that we have to explain why. why are individuals who are not dying from AIDS still look like they're dying earlier than HIV uninfected? And you may say, well, why is the HIV uninfected? Why is that not 78 or 77 or 78, what we would expect in the general population? As I said, these are individuals engaging in high-risk behaviors beyond just having HIV. Again, making the HIV uninfected in the cohort the better comparison group than just the general population. And these are the numbers for individuals who are currently dying of AIDS. We still have, I believe, about 50% of our cohort who are dying from an AIDS illness, and their time of death, you might say, this is still much older than it used to be, but the median times are approximately the same in the men and women, around 47, 48 years of age. So the age by which about 50% will die after the age 35 is, as I said, 75 and 64 in the men and women respectively. For those dying from a non-AIDS illness, it's 66 and 56, and about the same in the late 40s for those who are dying of AIDS. So, is that my cue that? Oh, no. So some of the analytical issues. It's really important to distinguish the period, cohort, and age effects. And I believe that using age now as the time axis is the appropriate time axis when we look at the development of outcomes in treated versus uninfected. You need to have the appropriate control group because you need to be able to address the confounding due to these other risk factors and also bias. You need to be following them the same way because if you wait till symptoms occur but you're on the detection of them for those illnesses, you will find them at younger ages in positive than in negative. So it's very important to be detection and looking at these outcomes without bias. It's also going to be important to address treatment history. We see that individuals who are experienced with other antiretrovirals have a different prognosis than those individuals who are naive. And so these also need to be accounted for and depends on, again, our mechanistic model of interest. I believe similar to what we have been able to elucidate in terms of the study of immunology, in the study of virology, in the study of illnesses, looking at HIV. HIV has been an incredible model for the science world. I think now that we're looking at mechanisms in terms of why HIV individuals develop these other illnesses, the HIV-infected and uninfected cohorts will actually be a model for understanding the mechanisms in these other illnesses as well. So the strengths of cohorts, you have individuals of similar risk. You have standardized, complete longitudinal collected with uniform. It's not because they're getting sicker, you collect more data on them, but it's collected with the same uniform frequency before and after treatment. And very importantly, the collection and the repositing of specimens. So now we were able to, like I just said, measure 13,000 person visits and look on markers of inflammation over time. And we're looking at the genetics also for predicting disease outcome, for looking at does it improve, is there a susceptibility gene for why some people are either resistant to illnesses or get them more quicker. So in summary, we have extensive information before and after the onset of treatment, that age may affect HIV progression before therapy, response to therapy, and adverse effects, that we know that HIV people are now surviving HIV under treatment, and that age is the time scale and equivalence issues are now key. And I want to thank not only the co-investigators, those I've actually mentioned by name during my presentation, the other PIs, the staff, but definitely the participants who have graciously given their time. You know, we talk about blood, sweat, and tears, what they really have in the max. I would say blood, mouthwash, you name it, they've given it. And this are my colleagues that I have not mentioned everybody by name, but on whose shoulders and who I stand next to for the movement of science in this area. Thank you.
That was great, and I was glad at the end. I was a little afraid you were going to list a slide of bodily fluids that people would contribute, so I'm glad you didn't go there. So I'm going to ask the first. I have a lot of comments and questions. Right? I'll do it after. But that last point you made about age, you know, so we we looked at this in the early 90s, in our cohort about, how to model the outcomes. And we were using Cox models. And, there's 3 time variables, right? As you said, there's age, there's follow-up time, and there's calendar time. And what we found is it didn't really matter to the hazard ratios which time variable we used, as long as we adjusted for the other one, right? So, but it's much easier to explain age when you
talk to people.
When
yes.
you talk to people, and so. But if you want to know what the calendar time effect is, then of course you put that in as a term. You don't use it as the age as the follow-up time.
One nice thing analytically is people in our group have done additional models besides the Cox model. So now we can use parametric models and find a model that best fits these data. And with age as the time scale, and with these parametric models, you can describe it not in terms of what increases the risk, et cetera, but what shortens the time. At what age do you expect things due to different levels of the risk factor that you're examining? So you can actually say that this increases, that you have 3 more years of age. So I think that's a very powerful, when we start talking about the shrinkage or extension of time and talking about it in terms of age. People like to think they're going to live longer, free of morbidity, free of disease.
We all like that. Yeah. So maybe I could just say one more thing. You showed those box plots of the IOXL GFRs, and that's got to be. And I know that it just was presented at CROI, I saw, but that's got to be highly confounded by street drug use and blood pressure, diabetes.
And we're looking at that. Yeah. So we've looked at diabetes. We looked at. And hepatitis C also is very important for looking at the GFR.
Given that you may have an appreciable prevalence of recreational drug use, that would be a really important. So I'll stop. Okay. Any comments or questions? Okay. Chris?
Lisa, thanks so much. Really, really a wonderful talk. I know it's sort of a complex question, but we tend to think of HAART as a therapy, but of course it's
multiple,
many therapies, and they've changed. And of course there is now really quite a divergence between the HAART regimens that people are on in the well-resourced settings and still some of these old, really bad drugs that are the backbone of so many developing country regimens. The question I have for you really is that in terms of teasing out the impacts of aging, the treatment effects, and the specific regimens, if there is enough data or if there are ways to look at and think about agents that in and of themselves might be contributing, for example, to inflammation, which is perceived by many, I think, to be the underlying mechanism, the chronic inflammatory activation.
Well, that is where the max by itself is not going to contribute that well. Because when you start thinking of individual, even regimens being used, multiple drugs, as you just said, there's a tremendous amount. Although there are becoming more consensus, and we are seeing more of like 25% on a particular regimen. I think this is where the combination of broader studies, such as the IDEA studies, including NA Accord, and then the smaller studies, so then we can look at specific individuals and inflammatory markers related to use of maybe a drug. Together, we can hopefully tease that out. But you need the larger cohorts. So I also think that the problem with the larger, very large cohorts is they don't have the specimens. So we got to work out a way. This is the new epidemiology, to take the breadth of information and the depth of the cohorts and try to make them compatible with each other to answer questions like that.
Can I ask another question? So you started out talking about frailty, and you have an intervention, right, in this group that reduces frailty. You put people on antiretroviral therapy and they get better. In the general, I don't know, maybe I should look at Joe Margolick and ask him, but in the general population, what clinical trial data are there to show you can reverse frailty?
There's been some small studies, and people correct me if I'm wrong, that has shown that for certain people that putting them on an exercise program, et cetera, can reverse or reduce the frailty. But typically in the general population, the frailty occurs at a much older age, and there's so many other issues and problems that are occurring and other morbidities that they have that it's very difficult that does represent an end stage situation. Joe, do you have anything further to add?
No, I think that's it. It's small exercise
Mhm.
studies, not long-term studies.
So maybe the mic.
Well, small exercise studies, not long-term,
Small
he said.
exercise.
Mhm.
It's on small exercise studies that are, not long-term reversible lifetime prognosis studies. And there are only actually very few longitudinal data on frailty in the HIV-negative elderly population, and they show it occurring at older ages and being much less reversible than it is in the max.
Mhm.
So like 97% if you're frail one year, you're frail the next year.
In the max, we do see that it can be reversed more. It's less of a persistent issue.
So, could you pass the mic over to? We're asking you to use the microphone because we record these, and if you're not on the mic, we don't hear it.
Okay. You had displayed data looking at the trail making,
Mhm.
and I was wondering if you had any other data dealing with cognitive
We do.
impairment, because
We
that's
do.
just looking at the speed, and that's only going to be one section of
So we do
neurological.
testing for executive function, speed processing, motor skills. So we do cover a lot of different domains in neurocognitive functioning.
And is it specific areas that are affected, or is it universal?
I can't tell you all of that right now. Most of the data has looked at right now symbol, digit, and trails, because that is collected every 6 months. And we've just started, not just, but we collect the other data every 2 years. And that's now being looked at. We know that depression is a big issue, though, in the cohort.
I think the most striking statistic I saw was the one that concerning the death of women in the non-infected women in the WIHS who die so much younger than uninfected men in the MAX.
Yep.
Any reason for that? It's standing out at this point. I mean, that's completely opposite of what you see in the general population. So.
But in this cohort of women, these are, don't forget, they were at risk for HIV, which means that they were either injecting drug use, they had multiple partners, they do other types of drugs, they're in a low economic situation. So there are other reasons that they do not represent the general population. And that's what's really important. When you talk about HIV, people at risk for HIV do not represent the general population. So if you're looking at burden of disease in public health, compared to the general population, but if you're looking at risk factors and the counterfactual of what would happen if they didn't have HIV or treatment, you have to use the at-risk population, the controls in the cohorts.
Okay. Well, I think what we're going to do is take it outside to the Wall of Wonder here, and or I think that's where it's going to be, and we'll have some wine and cheese. And Lisa, I want to thank you very much for a great talk.
Okay.